This big
So
blue
overview
baby.
of anatomy and physiology of the respiratory system. We have
You
ventilation,
can keep it. I don't like this one.
occurs as air moves into and out of the lungs through the process of inhalation and exhalation. Perfusion, movement of oxygenated blood into the tissues. Question for you, O2 and carbon dioxide are exchanged at what level of the respiratory system?
Alveoli.
Alveoli, good. Respiratory system is also responsible for these four things: acid-base balance, speech, sense of smell, and fluid balance. More anatomy from nose to diaphragm. So we have nose, mouth, sinuses, pharynx, larynx, trachea, bronchi, lungs. Mucociliary elevator, or some textbooks say mucociliary escalator. And it's the whole process of inhaling and any particles or mucus that comes down, it'll come back up through coughing or sneezing is basically that mechanism. Coughing and sneezing actually speed up. We do it with a lot of things, but especially when somebody's cold and you can, when you hear them congested ear, the cough or the sneeze expels particles. Visceral pleura, anybody remember that from anatomy?
It's the,
What is it called?
The serous membrane that covers the surface of each lung, and it dips into the fissures that are between the lobes.
Visceral.
Parietal pleura,
The visceral pleura.
outer membrane which is attached to the inner surface of the thoracic cavity, and it separates the pleural cavity from the mediastinum. And pleural space. The pleural cavity between the visceral and parietal pleura. Diaphragms at the bottom. What's the diaphragm do?
we should breathe.
Expands and contracts with inhalation and exhalation. Divides the abdomen from the pleural cavity. So we have inspiration, expiration, and respiration. During inspiration, the diaphragm contracts and pulls downward, while the muscles between the ribs contract and pull upward. During exhalation, the lungs recoil to force air out. And a respiration or a respiratory cycle is the one full inhalation, exhalation, the repetition of the pattern of inhaling and exhaling. Dead space, we have a couple different types of dead space here. And what it is, the volume of air that's inhaled that does not take part in gas exchange. Anatomic dead space is the total volume of the conducting airways from the nose and mouth down to the bronchioles past the bronchi. The alveolar dead space, alveoli that are ventilated but not perfused, so there's no gas exchange happening there either. That's why it's called dead space. Another term the textbook talks about is ventilation perfusion mismatch. And you'll see it called VQ mismatch. Can be caused by anything which increases or decreases ventilation, or increases or decreases perfusion to the lungs. Can be caused by anything which increases or decreases ventilation, or increases or decreases perfusion to the lungs. Anything that interferes with the ability of fresh air to get to alveoli and prevents the blood flow getting to the capillaries. So it's when, tissues receive oxygen, but it's not, the blood flow is not there.
Broke it.
Oh, it froze up on me too. There's a little thing at the bottom.
What?
No, there's a little. Someone, oh, there you got it. It's going now.
So assessment, what we're going to ask the patient is, what is their history of present illness? What brought them there? What's their chief complaint and the symptoms that they're presenting with? Ask them what factors exacerbate or improve the symptoms. If they're having pain, cough, or dyspnea. Important things about the history of present illness is asking where it's located, like, if it's shortness of breath, it's gonna be in their, upper airways. Duration, timing is very important. Modifying factors and associated signs and symptoms are very important. So if somebody were to come in with, complaints of shortness of breath, you would want to document patient has been short of breath for how long, for 4 days, with any ambulation. The shortness of breath subsides with rest. The shortness of breath gets worse with inclines. And patient also starts to sweat with inclines. So you want to be as descriptive as you can. Dyspnea means shortness of breath, so you can document SOB or dyspnea. You'll also see DOE sometimes, dyspnea on exertion. Flights of stairs. Some people with really bad lung disease might get short of breath with brushing their hair, brushing their teeth. Has anybody seen that yet in clinical? Shortness of breath with just such minimal exertion?
Oh, yeah.
You can expect shortness of breath with exertion. You'd want it to subside if they were to rest, okay? And it's bad news if it's not gonna subside with rest. So you need to document those things. So health history. I typed a lot so you wouldn't have to write notes. Current medications, all the medications, even their herbal supplements, anything over the counter. Allergies to environment, food, meds. Past medical history, especially respiratory related ones, any respiratory infections, any chronic respiratory disease. Any surgeries, especially pulmonary related. Family history of things, because there might be a genetic predisposition to some disease processes. Sometimes family history and occupation area residence is very similar, because the area of residence, you were there with your family, probably, especially your immediate family. So was it a family history, or was it truly, a product of the environment? Mold, dust, toxic substances, proximity to factories,
Pets.
pets, The, Roman Haas, which is in Bridesburg and Bristol, there's a lot of, predisposition to lung and other cancers in those neighborhoods because of the proximity to the factories that always emit toxins into the air. Smoking history, knowing and calculating what the person's pack year is. So the pack year is the pack, how many packs a day times the years they've been smoking. So if they've been smoking 1 pack a day for 20 years, their pack year would be 20. If it's a half a pack, then, you know, if it was a half a pack for 20 years, it would be 10.
Packs per day times years?
Packs per day times years.
Okay.
Smoking, like drinking, patients typically always downgrade the amount that they smoke and the amount that they drink. You know, if someone drinks a bottle of vodka, they might say half a bottle a day. If they drink if they smoke a pack of cigarettes, they might say half a pack. People seem to downgrade things to please the white coats. I'm not sure. Yeah, on purpose to not seem as addictive, I guess. What is their social history of drinking, illicit drugs? They ask that for almost everything. I was asked the doctor recently. And like, I had to really think, you know, how much I drink. I used to drink a lot more when I was younger and went out. Now I'm in bed by, you know, if I'm not here, I'm in 8 o'clock sometimes. So it's, you know, it's like social, like less than 4 times a year sometimes, you know, or 4 to 6 times a year. Like, how do you, I'm thinking, I don't even know how to quantify that. You know, I was thinking, you know, what do people asking, what are you doing this weekend? I haven't been invited anywhere. And my husband's like, you would bitch if we were invited somewhere, so shut up. It's true. I'd be like, I don't feel like getting ready and going, you know? So it's like a double-edged sword with being invited somewhere. Recent travel history out of the country. Was it an impoverished area that doesn't have good sanitation or whatnot? So physical assessment, we have inspection, auscultation, palpation, and percussion. So level of consciousness we're going to assess. Orientation, some confusion could indicate hypoxia if they have lung disease. Speech pattern, you know, some people with talking that have COPD or are in the middle of an asthma exacerbation, they could get short of breath while they're talking. So they might take breaks, they might talk fast so they can get it out and be done with talking so they can rest type thing. So the speech pattern can change with lung disease. Fingernail shape or clubbing, C-L-U-B-B-I-N-G, not going out partying, but clubbing when the nail is sort of straight across and flat and it doesn't have an angle to it. It's with chronic respiratory disease, people have the clubbing. It also looks like the fingers are wider at the top also. So inspect the mouth, you know, for any sores, mucosa, is it pink and moist? If they're dehydrated, what the mucosa look like? Not necessarily pale and gray, but if they're cyanotic, it would be dry or cracked maybe. If it's pale and, or cyanosis, what might that indicate? Hypoxia. The neck, you want to see if any of their accessory muscles are being used to inhale and exhale. Sometimes you might see their neck suck in and use of the accessory muscle under the scapula here.
Is that retracting?
Yes.
What is that word?
Retractable or retracting. Retractions. You're looking for symmetry too with the neck and the chest, the thorax. So retractions are the muscles pull inward during inspiration, and then it's called increased work of breathing, you know, they're not having an easy time of breathing.
Labor.
So we have tachypnea, which is respiratory rate above 20, bradypnea below 12, eupnea, which is, I always think of like euphoria, it's good breathing, you know, it's what we want is eupnea. And apnea, it says cessation of breathing, whether it's a couple times an hour, or just one long period of apnea. Who's at risk for sleep? People, what kind of people are at risk for sleep apnea?
Overweight.
Obese, people with big necks, some people just have big necks and aren't necessarily obese. Pulse ox should be what?
95 to 100.
Great, 95 to 100, at least 95. And then note any abnormalities with inspection. Symmetry is important. Symmetry is important with every assessment. So we usually have 2 of everything, right? So this here is talking about the next slide, actually. We have the normal chest, which is the anterior, posterior diameter. We want it to be 1 to 2. When somebody has chronic disease, respiratory-wise, it's going to be 1 to 1, and it's called a barrel chest. So the size of the chest, anterior is the same as posteriorly, okay? So normal is good, 1 to 2, barrel chest is 1 to 1. So palpation. So we're gonna palpate the trachea. Is it midline? Do we feel anything out of the ordinary? Anterior and posterior thorax, we just talked about. Is the patient pain when we're palpating? Is there crepitus? Crepitus is like Rice Krispies underneath the skin. Air trapped underneath the skin and feels like crackling.
Isn't that emphysema? Because
Could be.
Oh, okay. I had a patient that had subcutaneous emphysema, and it was the same exact thing.
Yeah, you'll hear that be called crepitus. Usually caused by a trauma, collapsed lung, pneumothorax. Is the equal expansion of the lungs. Tactile fremitus is another palpating assessment. You stand behind the patient and you put one hand on each lung field and you ask the patient to say 99. And we should feel the same vibrations bilaterally. If one side is less vibrating, I don't know what word I'm trying to find. If there's more or less vibrations, it could be indicative of pneumonia or pleural effusion when the lung fields are filled with fluid. It's not going to be as vibrating. Vibrating is not a word, but that's the word. That's the best word I can use to describe it. So pneumonia has like fluid or pus-filled alveoli. Pleural effusion is excess fluid in the pleural space outside the lungs. So you'll hear, you'll feel a difference.
So for that, will the fluid only be in the pleural, or can they have like pneumonia or something?
They could have both. They could have pneumonia and a pleural effusion. So it would be extra dense because of the fluid internally and the fluid outside in the cavity.
So would you probably, anterior or?
Anterior, you're gonna have the breasts in the way, typically, or even, chest mass in men, so, you're gonna feel it better posteriorly. Pneumothorax are usually, caused by trauma. Air leaks into the space in between the lung and the chest wall. The excess air outside the lung forces against the lung and compresses it, makes it collapse, so that's what a pneumothorax is. Knife stabbing, gunshot wounds can cause a pneumothorax.